Welcome to the Sports Docs podcast with Dr. Ashley Bassett and Dr. Catherine Logan. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice.
Today, we're coming to you again live from the American Academy of Orthopedic Surgeons annual meeting in Las Vegas, our largest orthopedic conference. If you haven't listened to our previous mini episodes, what are you waiting for? Go check out our first mini episode to hear all about AAOS meeting and our special guest, Dr. Brian Waterman. But today, we're going to dive right in.
We are supported by SportsMed IQ, where you can find all the tools you need to be your best in sports medicine and recovery. Go to sportsmediq.com to access blogs and a weekly newsletter highlighting the latest research and trends to care and injury prevention, treatment, and recovery.
You also find links to each of our podcast episodes, access to educational courses, and links to our favorite products. I created this site to house all that I've learned over the last 2 decades as an orthopedic surgeon, physical therapist, and personal trainer. So check out sportsmediq.com for all your sports medicine needs.
You can also find links and code information on our Instagram page. Our third poster is titled Pediatric Anterior Cruciate Ligament Reconstruction. Adding lateral extra-articular tenodesis resulted in similar return to sport without increasing pain scores. Ted Ganley and his colleagues at CHOP performed a retrospective chart review to determine first, clinical factors that motivate surgeons to perform a lateral extra-articular tenodesis, or LET, at the time of ACL reconstruction, and second, to compare early clinical outcomes between patients who underwent an ACLR alone versus an ACLR with LET.
We did our first overtime episode on LET back in November of 2021. So if you'd like to learn more about this procedure, including the indications and its clinical outcomes, go listen to that episode. Briefly, the addition of an extra-articular stabilization procedure, such as an LET or ALL reconstruction, has been shown to reduce the risk of graft rupture in adults, but there's limited studies in the pediatric population.
The authors found that the Beighton score for the ACL plus LET group was significantly greater than that of the ACL alone group. Second, LET procedures were more commonly performed in revision surgery rather than primary ACL reconstruction. This study suggests that greater ligamentous laxity as measured by the Beighton score, as well as the patient requiring a revision ACL reconstruction, may make surgeons treating pediatric patients more likely to offer LET or ALL reconstruction. Lastly, the study suggests that the addition of LET resulted in similar pain levels, sports clearance times, and post-op mobility compared to ACL reconstruction alone. So this area certainly has limited literature in the PD population. Brian, do you feel you need to know more before adopting this in your pediatric population? If so, what should future research try to address?
Yeah, I'll be honest, I was a little hesitant to do it in the primary setting and had been more judiciously using it in a revision type of scenario. We then joined the Stability 2 trial group. As you may recall, Stability 1 was I'll Get Good study, multi-center, and that looked at hamstring with or without LET, or the modified Lemaire procedure. And they found that at least maybe up to half those individuals can have a risk reduction in secondary failure. They also show lower rates of laxity. So I think there are 2 endpoints that you can really hang your hat on in that. When it comes to Stability 2, we're looking at patella tendon and quad tendon, and so what we want to see is, does the risk of secondary re-rupture, does it get dampened by the addition of the LET? So, we're including everybody from 14 on through 25, high-risk subset, recurvatum, Beighton greater than 4, and those are individuals that are being randomized. And through that, individual experience has told me that, 1, there's very limited donor morbidity. 2, you can do it very safely, especially in somebody that has open physes, although it's an exclusionary criteria. Okay. And then 3, I think there is a protective effect. And oftentimes when I'm counseling patients about this as a potential research study, often they say, hey, I don't want to be part of the research study, but if there's a chance that it could help me out, I'd like that. So I opt out of the study, give me the LET with whatever your graft of choice, which is fascinating.
What grafts are being included in that study? Is it all a quad,
patella,
BTB, and hamstring?
So 4 groups: patella tendon with or without LET, quad with or without LET.
Okay, so no hamstring.
No
okay.
hammy.
Got it.
And so that's going to be upwards of 1,200 individuals enrolled, the largest ACL study. I think what this does for me, though, it really looks at that unique patient subset we know to be at high risk, right? Pediatric and adolescent group. We had the fortune of having this as being one of our featured papers on the poster tour that we had the first day, and fantastic discussion. They're pooling a lot of their data from their single center, so there's a little bit of a mixed bag, right? Primary, revision, variety of different graphs, different techniques utilized. What I take from it is, even in a higher risk subset, right, because they had higher Baton score and maybe a higher activity level, they had a lower re-rupture rate in the LAT group, and they showed that the pain scores were actually better in the LAT group and the promised pain interference.
That's better than the initial study by Getgood and his team found pain was higher and recovery of quad strength was also slower, but that by 12 months it was all equalized. So that's interesting that that pain was lower in the LAT.
Yeah, and what they showed in their secondary study was that at 12 weeks the pain scores were pretty on par with each other. Yeah. And I tell patients that. I think we've also gotten some useful feedback on how you can maybe stack the deck even more towards less pain. One of my colleagues, Bruce Levy, and I were having this conversation, and he says, a lot of people will close that IT band defect completely. He said, I close it to just shy of the joint line, and that's to prevent muscle herniation. But if you do too much of that, it makes it excessively tight. I think that the staple fixation is also another pearl that I've taken from this study. There's a higher rate of secondary hardware removal, so I generally go with an all suture knotless mechanism. I think that's really nice as well.
Nice, yeah. I like that. I do that as well too, and I like it because it's a lot smaller, and I feel like tunnel convergence is a real concern with those, so I like that technique a lot.
So I think that's really exciting. I'm really looking forward to seeing the results of Stability 2. I think it's much more applicable to sort of how both you and I actually practice. So with quads and BTB, so more so than hamstring, I really am looking forward to seeing these results and hopeful for good things to come. But I also want to bring up, you were on a panel at AAOS about this topic. It wasn't just pediatric. You guys spoke about late adolescent as well as adult patients when you were doing your case studies for this AAOS panel. But so I'd love to hear a little bit about your thoughts on how this is going to change your practice or where you see LET fitting in.
Yeah, so I'm really excited to finally talk about LET with a voice. So if anyone was in attendance at that panel, they know that I had no voice and I was not able to articulate my thoughts and how much I love the addition of LET to high-risk ACLs out there because I had no voice. But now my voice is back and I'm so happy to talk about it. So here we go. So I think LET really is the future. There's studies coming out left and right just talking about the addition of LET to high-risk patients. So what is a high-risk patient, right? Well, the Alan Getgood study, the original stability study, found that patients with generalized ligamentous laxity, so a Baton score of greater than 4, knee hyperextension greater than 10 degrees, participation in competitive cutting and pivoting sports, they categorize those 3 as high risk. And in their study, you needed to have 2 of those 3 in order to be deemed high risk in terms of being in that cohort. So there's a new study that just came out by Kyle Bork and his team at the Fortius Clinic in London that looked at the addition of LET to primary ACLs in elite athletes. So the only high risk was the fact that these were elite athletes, and they found a significantly decreased risk of ACL graft rupture. So suggesting that we should be broadening these indications. So I think this is a great paper because a lot of times, especially with literature and research, we tend to shy away from implementing some of these things in the pediatric population, but we know that pediatric patients are at significantly increased risk of having an ACL re-tear. Young age is a very high risk factor, and having an ACL injury is an increased risk factor of having another one. So I think the addition of an LET can decrease the risk of ACL graft rupture in this population. So I'm really excited. I was really excited to see the results of this paper or this poster, and I look forward to reading the paper and seeing more come out about this.
Yeah, and I think it is great that it didn't slow down the recovery. Do you change your post-op recovery, like your protocol? I do not.
I do not.
Yeah. So, it should be the same, but they do have an additional incision. I know that if I use adductor blocks, which I generally do, you're not getting that lateral pain coverage as well. So it's good to see that they had similar pain levels, and I'm not surprised that they had the same sport clearance times, because the rehab protocol shouldn't change, but it's, seeing that the post-op mobility was same to ACL alone is also a good thing. So happy to see all these results. I do think it is going to be a bigger and bigger part of our future, and I'm excited to see those stability 2 results.
Yeah, I was really looking at this. I was surprised about the pain levels being comparable, because the stability study did show that initial pain was higher. I think it equalized around 6 months post-op, and that there was some quad strength deficits, but those also equalized at 12 months. So, you can tell your patients, we're not going to change your recovery. It may be slower. You may have more pain, although this poster suggests you won't. But ultimately, in the end, everyone has equivalent clinical outcomes in terms of patient-reported outcomes and equivalent return to sport. And that's, I think, what really matters.
Yeah, and I think some of that stuff they'd really have to select out for revisions. Like if this is a revision population, I also expect that sport clearance time is going to be a little slower. Post-op mobility might be a little bit slower. Like all these sort of things are going to affect it. But if it's more of just hey, this is a high-risk person, this is the primary reconstruction, then, it seems like it's just going to be pretty standard fare, which is exciting.
Absolutely. Thank you for listening to this mini episode of the Sports Talks. We hope you enjoyed the discussion as much as we did. On the next mini episode, we'll continue our conversation with Dr. Brian Waterman and shift our focus to hip arthroscopy and discuss the impact of age on time to achieve acceptable clinical outcomes. Make sure you subscribe on iTunes, Spotify, or wherever you get your podcasts to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review. You can also reach us by email at thesportstalkspod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.